part two of the major depression recurrent episode from the case files psychiatry book. So we finished with the case, we finished with the definitions, clinical approach. And now we'll start with the differential diagnosis. It is important to rule out other disorders that could be causing a depressed state, including medical diseases, medications, or substances. So, it is important to rule out other disorders that could be causing depressed state, including medical diseases such as hypothyroidism or multiple sclerosis. Also, to rule out medications that cause the depressed state, such as antihypertensives, and substances that could cause that, such as alcohol use or cocaine withdrawal. Obtaining a thorough history, performing a physical examination, and ordering appropriate laboratory studies are crucial in the assessment of any new onset of depression. Many psychiatric illnesses are characterized by depressive symptoms, including psychotic disorders, anxiety disorders, and personality disorders. A critical distinction to make, especially in recurrent episodes of depression, is between major depressive disorder, recurrent, and bipolar disorder, depressed. This distinction is essential not only for making the correct diagnosis, but also for proper treatment. Standard therapies for major depression can be less effective and actually worsen bipolar illnesses. It is necessary to obtain any current or past history of episodes of mania, as well as any family history of bipolar disorder. Assessment of suicidal risk. One of the most important determination as a clinician must make in the case of a depressed individual is the risk of suicide. The best approach is to ask the patient directly using questions such as, are you or have you ever been suicidal? Do you want to die? A patient with a specific suicide plan is of specific concern. Also, the psychiatrist should be alert to warning signs such as an individual becoming uncustomarily quiet and less agitated after a previous expression of suicidal intent, or making a will and giving away personal property. Risk factors. Risk factors for suicide include older age, alcohol or drug dependence, prior suicide attempts, male gender, and a family history of suicide. So risk factors for suicide include older age, alcohol or drug dependence, prior suicide attempts, male gender, and a family history of suicide. The results of a careful mental status examination, risk factors, prior suicidal attempts, and suicidal thoughts and intent must be well considered. Now we'll speak of postpartum depression. Women report some emotional disturbance or problem with cognitive functioning during the postpartum period. Many experience what is known as postpartum blues. Postpartum blues, in which there is sadness, strong feelings of dependency, frequent crying spells, and dysphoria. These feelings, which do not constitute major depression and therefore should not be treated as such, seem to be attributable to a combination of the rapid hormonal shifts occurring during the postpartum period, the stress of childbearing, and the sudden responsibility of caring for another human being. Postpartum blues usually last for only several days to a week. In rare cases, postpartum depression exceeds in both severity and length that observed in postpartum blues and is characterized by suicidality and severely depressed feelings. Women with postpartum depression need to be treated as one would treat a patient with major depression, taking care to educate them as to the risks of breastfeeding an infant when the antidepressant appears in the milk. So, postpartum blues are not treated as major depression. Postpartum depression must be treated need to be treated as one treats a patient with a major depression. Postpartum blues and postpartum depression. There is a distinction. Left untreated, postpartum depression can worsen to a point where the patient becomes psychotic, in which case antipsychotic medication and hospitalization can be necessary as well. So, treatment in individuals who suffer from one episode of major depression, there is a 50% to 85% chance of having another episode. The risk of recurrence increases not only with each subsequent episode, but also with the occurrence of residual symptoms of depression between episodes, comorbid psychiatric disorders, and chronic medical conditions. So the risk of recurrence increases not only with each subsequent episode, but also with the occurrence of residual symptoms of depression between episodes, comorbid psychiatric disorders, and chronic medical conditions. Therefore, adequate treatment resulting in full remission is the goal. The treatment options for recurrent episodes of major depression are not significantly different from those for a first episode. Pharmacotherapy, psychotherapy for a mild or moderate symptomology, so pharmacotherapy, psychotherapy, or combination of the two, or electroconvulsive therapy, ECT, in major depression with psychotic features or where a rapid response is required. Common first-line pharmacotherapy for episodes of major depression includes selective serotonin reuptake inhibitors, venlafaxine, bupropion, mirtazapine, and duloxetine. So, venlafaxine, bupropion, mirtazapine, and duloxetine, as well as SSRIs such as fluoxetine, sertraline, paroxetine, and citalopram. These are common first-line pharmacotherapy for episodes of major depression. Side effects vary among the specific medications and include sedation or activation, weight gain, headache, gastrointestinal symptoms, tremor, elevated blood pressure, and that elevated blood pressure for venlafaxine at higher doses, and sexual dysfunction, particularly with SSRIs and venlafaxine. Although efficacy is essentially equivalent among all classes of antidepressants, tricyclic antidepressants such as desipramine and nortriptyline are usually not considered first-line agents because their side effects are less well tolerated, including anticholinergic effects, orthostasis, and cardiac effects leading to lethality in overdose. Monoamine oxidase inhibitors are used less frequently because of their significant drug-drug interactions and because dietary restrictions are necessary. A rule of thumb in managing recurrent episodes of major depression is that the particular medication that achieved remission in past episodes is likely to achieve remission in subsequent episodes, often at the same dose. Additional factors to consider when choosing a medication are prior side effects, drug-drug interactions, cost, and patient preference. So finally, we have the clinical pearls of this case. It is important to rule out an underlying substance, medication, or medical condition causing depression, especially if the patient does not have a prior history of depression. More than 50% of patients who have had one episode of major depression will have recurrent episodes. The risk of further episodes of major depression increases with the number of prior episodes, the occurrence of residual symptoms of depression between episodes, and any comorbid psychiatric or chronic medical illness. The treatment that was successful for prior episodes of major depression has a higher likelihood of achieving remission in future episodes. And finally, selective serotonin reuptake inhibitors as well as bupropion, venlafaxine, mirtazapine, and duloxetine are all first-line treatment options for major depressive disorders. Thank you very much for listening, and this is all for our psychiatry case from the case file psychiatry book. As I mentioned, I'll be doing one case from this book and one case from each of the other two books, and we'll see a different kind of book later on, or maybe we will cycle. We will see, inshallah. Thank you very much for listening. Please have a nice day. Don't forget to like, subscribe, share, and comment.